Assalamu alaikum. I'm Dr. Muhammad Ali Rabbani. I will be your guide for the next lecture on the general anatomy that is on the topic of bone and cartilage. By the end of this lectures, the listeners should be able to define bone, what is the bone, enumerate its functions, anatomical or physical and physiologicals. We will classify the bones on various classifications on the basis of their architecture, on the basis of regional distribution, shape and size, and embryological development. We will briefly go through the general structure of the long bone, quickly go through and define various terms that are related to impressions and markings on a bone, and then we will try to classify the cartilage and look at the examples of each of them. So let us start our lecture with bone. What is bone? It is simply a specialized form of connective tissue that is characterized by the extensive mineralization of the extracellular matrix. Mostly it is impregnated with calcium phosphate salts. There is a saying about the bone that it has a strength of a cast iron and lightness of a pine wood. We will go through its structure, but that's how we usually explain its strength with accompanied lightness. Like any other connective tissue, it consists of three components: cells, fibers, ground substance. The cells, three majorly associated cells are osteoblast, bone forming cells, osteoclast, bone dissolving cells, and osteocytes, the cells that are resident of the bone. We will go into the detail usually in the lecture of histology, but here you have to just keep mind of the fact that the cells that are usually the resident of the bone are osteocytes in majority. Again, osteoblast and osteoclast are there. Fibers, those are in majority are the collagen fibers that are giving tensile strength to the bone. And the ground substance, it is heavily impregnated with salts, especially calcium and phosphate based one. As you can well imagine, the functions of the bone, it is the basic framework that is supporting the body. The all the muscles are attached here, the organs are supported by it. Ultimately, the whole body is put together around the bony skeleton. So it's the framework to maintain the structure. It protects the vital organs. You can see in the skull there is a cranial vault that houses the brain. In the thorax there is a rib cage that houses the lungs, the liver, hair, and heart, most importantly, among the other organs. Similarly, same goes for the pelvis and the structures that are present there also. Humans are highly mobile organisms. You can have movements of various parts of the body, and you can move around from one place to another. That is the locomotion, and that is made possible with the help of movements in the skeletal muscles, and the movements are generated through the forces transmitted to the bones, and the movement are done across the joints. So this system of levers is provided by the skeletal system, the bones, and the energy, the driving force is the muscles there. So the system of levers that is provided by the bone. If we talk about the physiological functions, one of the very important function is that it houses the bone marrow. The inside of the bones contain bone marrow, that's the site of the hematopoiesis, blood cell formation, and last but not the least, The minerals that are deposited in the bone not only provide strength to the bone, those act as the reservoir of those chemicals for whole of the body. So 97% of the total body calcium is deposited in the bones, and the calcium is also required for a lot of other functions in the body also, like maintaining the potential of the nerves, potential of the muscle, membrane potential, and for that the body has to maintain a certain level of calcium in the blood. So that act as a storehouse, that act as a reservoir where extra calcium can be deposited, and when there is a lack of calcium, it can be taken out to use in the body. Let us talk about classification of the bones. We can classify the bones on various grounds, on the basis of the tissue architecture, on the basis of regional distribution, size and shape, and how they are developed embryologically. Let us start with tissue architecture. You don't have to go in microscopic details. When you have bone cut up, you can see the bone divided into two parts. The outer part that is usually dense layer, visibly you cannot see by grossly, by naked eye you cannot see any spaces among them. So this compact layer is known as compact bone, and as it is on the outside cortex, that is also known as cortical bone. Even if it is has canal system when we visualizing them microscopically, but it appears solid to the naked eye. Then there is spongy bone. The name gives it away. Like any sponge, like any foam, if you cut it up, you can see a lot of trabeculae going and joining and forming a meshwork in every way direction. And between them, there are spaces that are totally interconnected with one another. So that is spongy bone. And that interconnected cavities that usually houses the bone marrow, the hematopoietic cells that generate the cells of the blood. Let me show you through them through a picture. So this is femur, the bone of the thigh. So in the shaft you can see this part. This is the outer compact part. This is the compact bone. And inside it, this whole area, this sponge-like area, this is called spongy bone. As you move away from the shaft to the head, the definitions hold, but the compact area is limited to a thin layer near the periphery, and the most of the inside is filled with the spongy bone. That is shown a little more clearly in this picture, where the outer thin layer of compact bone is shown, and inside there is calcaneus bone. In the long bones, there is another empty space usually. As you grow old, as the bones grow larger in diameter, you grow higher in height, longer in height. The shafts are usually empty from the inside. These are known as medullary cavities. We will talk about them shortly. So this is the compact bone. And don't forget to look at the alternate names as they may be asked in your exams. The compact bone, also known as cortical bone. Spongy bone are known as calcaneus bones or trabecular bones. Trabeculae, from this meshwork of trabeculae, the spicules that are going through them. I have mentioned that both the compact and trabecular bone have similar lamellar arrangements. As we move to the histology section, we will see that they are microscopically have very regular arrangement layer by layer known as lamella. So this is shown right here. This is a bone. This is a bone of the arm. This area, humerus. They have taken picture from here. The outer part, this is the compact bone. The compact bone, although it is appearing solid to the naked eye, it has a very regular arrangement of this Haversian system. Haversian system is this system of osteons where there is a vertically running canals running along the length of along parallel to the shaft of the humerus, and along them the bone tissue is arranged concentrically. One circle, this is one lamella, then other lamella, then another lamella, and inside them, these dots you are seeing, these are the spaces, these are the lacuna in which osteocytes are residing. And these spaces, these Haversian canals, are housing the arteries and veins and nerves and some lymphatics that are in the bones. And if you come to see here, the spongy bone, although it does not have the proper Haversian system, the concentric canals, but still you can see if you cut any of the trabecule and look it under the microscope, you will see it has a similar arrangement of layer by layer, similar lamellar arrangement. To go into the further details, to differentiate between circumferential lamella and, and different types of interstitial lamella, we will go into the detail when we are discussing the subject of bone in histology. For now, this detail will do. Let us now classify the bones on the basis of their regional distribution. On the basis of regional distribution, there can be two major groups: the axial bones, the bones in the midline that form the axis of the body, that include all the bones of the skull, the vertebral column, rib cage, sternum, and bones of the pelvis, sacrum, and coccyx. Then there is appendicular bones. Appendicular bones include the bones that are present in the limbs, from scapula, clavicle, all the way to the fingers, that are phalanges and metacarpals, and here hip bone to all the way to the bones of the foot. So these are the different bones that are present in the body. Here, make one correction that I mentioned in the previous slide. Pelvic girdle, hip bone will be counted in the in the appendicular skeleton. So axial skeleton will include all the bones of the skull. There are total 22 bones. As you move on to the anatomy of head and neck, you will count them all. I'm not going to call all of the bones right now, but there are 22 bones, including the 6 bones that are present inside the ear. Then there's vertebral column. There are 26 bones, sternum, 12 ribs on each side, 24, and hide bone, a bone that is present in the neck right here. So these are total about 80 bones. Then there are bones of the upper limb. Then there are bones of the lower limb. In the upper limb, there is clavicle, scapula, humerus, radius, ulna, 8 carpal bones, 5 metacarpal bones, and then 14 phalanges. Lower limb has a similar arrangement of pelvic girdle, that is hip bone, one on each side, femur, patella, tibia, fibula, and then there are 7 tarsal bones on each side, 14 in total, and then 5 metatarsal and 14 phalanges. So these make up a total of 206 bones. Now, let us classify the bones on the basis of their size and shape. Long bones. Long bones, as the name indicates, are long. So they are usually longer in one direction as compared to the other direction. So when thinking about the long bones, you usually think about the bones that are present in your limbs. This humerus, radius, ulna. In the legs, femur, tibia, fibula. Yes, that's right. That are the typical or long bones. And even the small bones of the hands that are longer in one direction than the other will be considered as long bones. In the hand, you can think about the bones that are present in the palms, metacarpals. It will run from here to here and it will be just this wide. This is the miniature long bone. Similarly, the phalanges, it's only this big, but it is much longer as compared to its width. So these are known as miniature long bones, metacarpal and then phalanges, and in the foot there will be metatarsals and the phalanges. So these are all examples of the long bones. Short bones, these are roughly approximately equal in their various lengths. If you consider anteroposterior, superior, inferior, and of course not exactly equal but comparable. So these usually include the bones that are present just here, just distal to your wrist, that is the eight carpal bones, and the bones that are present in the foot that are known as tarsal bones. These are the tarsal bones that are shown. As you go on to the anatomy of the limbs, you will learn their names. I'm not going into them right now. The flat bones. The name indicates they are compressed in a plate-like fashion, in a sheet-like fashion. These include the bones of the skull. Those are like sheets covering the whole brain as a cranial vault. The bone in front of the chest, that is the sternum. The ribs are included in that. So these are the flat bones. Irregular bones. Irregular bone, as the name indicates, they are they cannot be defined in a particular shape. They are irregular in their shape. So basically, it's the classification by exclusion. One of the very good example is the vertebra. So it has a body here. It does not have a very symmetrical. It has a symmetry, but it does not fall into any of these long or short and flat. So it has a body here, processes on the side, process on the back. There is a cavity in the middle. So this is irregular bone. Similarly, hip bone has a very peculiar shape. So that is counted in that also. Then sesamoid bone. It's not as so much as talking about on the basis of shape and size, but more focused on its location. These are the bones that are present where the joints cross, where that crossed by the tendons. This is the shown on the kneecap is shown right here from the anterior view. Let us try to draw it on the side view. This is the bone that is in the hip, that is in the thigh femur, and then there is a bone that is present in the leg, tibia. So if there is a muscle that is all the way here that is going to be inserted into this that is going to be inserted on tibia, you can well see that it may not be in a very ideal position to move the tibia anteriorly. So nature has devised a way in which if there is a extra bone here, it may help in changing the angle of the muscle pull and give the muscle a mechanical advantage. Now, if there is a patella bone here and the tendon goes from there to this direction now the bone is pulled in this direction. It has a very easier chance of straightening. It is in a more mechanical advantage now. So this is the sesamoid bones. These are usually present where the muscles are attached to the bone across the joint via tendon. So they give resistance across the bone and they give a mechanical advantage to the joint in a particular movement. Then these are accessory bones. These are the bones, accessory bones, these are extra bones. These are the bones that are not usually present in all of the people. So they may be present in some, but not in the others. So extra bones, accessory bones, these are not usually counted in the 206 bones that we mentioned earlier. One example of the supernumerary bone is the bone that is extra ossification center that is formed along the fifth metatarsal and it is not fused with the bone. This is os vesalianum. There are other examples too. Then there is example of Vermian bones. In the next lecture of the joints, you will be introduced to sutures, fibrous type of joints. So these are basically the joints between two flat bones where there is minimum of cartilage, only fibrous tissue. It's like a zigzag pattern, a wavy pattern where two bones are joining. Sometimes the pattern does not only include the two bones, but in between these line of fusion, some bones become isolated, some bones become strapped. So this is a vermian bone. This is a vermian bone. This is an occipital bone. This is the parietal bone. This is the joint between them. And in the wavy joint, this bone is isolated. This bone is isolated. This bone is isolated. Such bones which are in the sutures and become independent of either of the two bones, making the joint, these bones are known as vermian bones. And last but not the least are hypertrophic bones. Hypertrophic bones are the ones that develop inside the tendons in response to repeated injury. In the previous lecture, you were introduced to the terms of position and movement. You were introduced to the term adduction. So, when you ride a horse, you forcefully adduct the thighs to keep your grip on the horse so that you don't fall off. So the adductor muscles are acting very forcefully. A particular muscle, adductor longus, it has a very small origin point in the hip bone, in the pubic bone. When the muscles in riders, when the muscles are constantly in a state of contraction and they are repeatedly used, this point gets injured a lot, and ultimately to cope up with the stress, that part that develops fibrous tissue and ultimately ossifies, and this area develops a bone that is known as rider's bone. The people who rides the horses very frequently develop such bones in their adductor muscles near their origin sites. So these are known as rider's bones. So these are the bones on the basis of their shape and size, and of course this classification does deviate a little, talking about their location and being accessory in nature. So this is about the classification in this. Moving on, the next one is how the bones are developed embryologically. There are two basic categories, and third one is the intermediate between them. Membranous bones, membranous ossification. Here the embryonic tissue that is known as mesenchyme, it first condenses to form membranes. It sheets where the future bone is to be formed, and then centers of ossification start in them, and the whole membrane is gradually ossified. There is no intervening stage of forming a cartilage. If you might have seen some videos on the social media of freezing a water bubble, freezing a soap bubble, it's somewhat like that. In very cold conditions, if you blow a soap bubble and put it in below freezing points, then there's a crystal that starts forming, and it's at multiple points, and they spread and spread and spread until all of them fuse with one another, and there is a whole confluence of frozen ice crystal. So this is somewhat the examples of how the membranous bones develop. There is a membrane, there is a point the of ossification starting, and more than one are there, and they bones spread away, bones start forming away from that point, and ultimately all of them join to form one confluent long bone. So the bones of the skull and the flat bones of the face, they develop through this mechanism. Cartilaginous bones, most of the long bones and a lot of the irregular bones, they develop with this system. First in the embryo, for example, talking about this humerus bone, first the whole model of humerus is made up of hyaline cartilage. Then there is a mechanism, again we'll go into the detail in histology, through which that cartilage is gradually replaced by the bone. So these are cartilaginous bones. I will show the pictures in the next slides. Most of the ribs, limbs, bones, long bones, vertebra, they develop through this. And then there is a method that is intermediate between them. There are some bones that partially develop from both methods. A very good examples are this bone, clavicle, the horizontally running long bone in the above in the collarbone also known as, and then there is mandible, the jawbone. So this is the basic schema. The mesenchymal cells arrange in membranes. In the membranes, ossification center appear and they spread out to form the bone. In enchondral or cartilaginous ossification, the mesenchymal cell condenses to form the cartilage skeleton. The cartilage in the center, in the shaft of the cartilage, ossification center appears, that is known as primary center of ossification. It appears usually in the third month of embryonic development. It spreads out to ossify the shaft, and the ends usually develop their own centers of bone ossification. So these usually develop in the late pregnancy or immediately after birth. So these points, they form the secondary centers of ossification, and as you grow old, these spread out to replace the cartilage, and then there is a cartilage that is remaining between this secondary ossification center and primary ossification center, that is known as growth plate. As you grow in age, as you grow in height, this growth plate continue to give length to the bone till you have grown enough. Then this cartilage also disappear and the secondary ossification center fuses with the primary ossification center, and bone is continued as a single unit. Now, the structure of the long bone. The bones may have very long bones may vary a little in the shape, but their general structure, their basic structure remains the same. Let's start from center outwards. This whole shaft, the long cylinder of the bone, this whole shaft of the bone, this is called diaphysis. Simply shaft of the bone is also used. This is known as diaphysis. This is the shaft of the bone. It has compact bone on the outside, cortex, and then there is marrow cavity on the inside, the complete absence of the bone. There is like a hollow tube. You must have eaten meat, and in even in all the animal meats, you must have, especially if you're eating red meat, you might have encountered such bones where the bones are like a ring. Basically, we are using the bones of the limbs, which has in the center there is bone marrow. As you grow old, it is replaced by a yellow bone marrow, which is non-hematopoietic cell, mostly consisting of fat cells and stroma. So this is the marrow cavity, and if you remember, we saw this briefly in the pictures in the histology right there. We saw in this picture. So this area was the compact part that has again osteons and longitudinally running Haversian canals and horizontally running Volkmann's canals or perforating canals that are joining these. And then there is part of the spongy bone, and then in the inside there is complete absence of the bone, that is known as medullary cavities. Next is the epiphysis. Basically, epiphysis is the part that develops from the secondary ossification center, that are the parts near the ends. These are the ends of the bones. This is an epiphysis, this is an epiphysis. Again, we'll go into the detail as they can be considered as several epiphysis also. This whole part is the epiphysis. It does not have a medullary cavity. That cavity is only present in the shaft. It has a layer of the compact bone outside, shown by the solid coloring, and spongy bone on the inside. And these parts usually retain red bone marrow till uh, older age. Then this slanting area, this sloping area between the epiphysis and the diaphysis, this sloping area is called metaphysis. Then we talked about the medullary cavities. In young children, it is filled with red bone marrow hematopoietic cells. As you grow old, even in your 20s, it rapidly starts to be replaced by yellow bone marrow, and it does not participate in the blood formation. The blood formation is limited to the small parts, the epiphysis, and the small and irregular and flat bones. And it has periosteum and endosteum. For that, I will go back to that picture. If you see a bone, the outside it is lined by a fibrous tissue that is known as periosteum. It is a combination of connective tissue, and then there are blood vessels that are running in them, and it on the inside, the outside there is majorly fibrous tissue, fibrous layer. On the inside, that is the cellular layer. It is a relatively higher percentage of cells, and the important cells related to the bone functions, these are osteoprogenitor cells that can give rise to the cells forming the bone, osteoblasts, that will increase the thickness of the bone. We will go to that shortly also. Similarly, on the inside, it is lined by a layer of cells. This is known as endosteum. It is shown in this picture. This is the lining, bone lining cells in the inside. These are endosteum. They also contain osteoprogenitor cells. They can help in the growth of the bone from the inside. And these are the lining on the outside of the bone towards the surface. This is periosteum, and the lining of the bones in the inside towards the medullary cavity, around the spongy bone, inside the osteons. These are known as endosteum. Then there is epiphysis types. We talked about the epiphysis, this part that was developed from the secondary ossification center. Depending upon its function, it can be divided into different types. Pressure epiphysis. These are the parts where the epiphysis, the end is receiving a pressure. If you think of your lower limbs, the head of the femur shown here, that is receiving your weight of the body. The lower end of the femur and the upper end of the tibia, both epiphyses are receiving pressure. These are not being pulled. So basically, most of the epiphyses at the joints. So that will include the lower end of the humerus and the upper end of the radius also. So these are under pressure. So these are pressure epiphyses. Traction epiphyses. These are not usually part of the joint, but these are projections that are usually place giving a place for the pulleys, for the ligaments, for the tendons of the muscle to attach, and the bone is pulled at those points. So muscles pull. This is the greater trochanter of humerus, femur. I'm sorry for that. Greater trochanter of femur, lesser trochanter of femur. Here, various muscles are attached. They pull and they move the femur, and so this epiphysis is known as traction epiphysis, and they are not part of the joints. Atavistic epiphysis. These are the bones which, in embryologically less evolved animals or different animals, these were independent bones, but with evolution, they become fused with the bones. A good example is coracoid process of the scapula. In birds, in other animals, it may exist as independent bone, but in humans, it has fused with the scapula and is counted at one of its processes. This is known as atavistic epiphysis. And last but not the least, aberrant epiphysis, that are deviations from the normal, that are not usually present in all of the people but present in some. For example, the metacarpals, there are five metacarpals in your hand. There is only one epiphysis, one secondary ossification center at the lower end, of first one and one ossification center at the upper end of the second to fifth one. What if this metacarpal develops another one at the upper end? So that will be aberrant epiphysis because it is not present in everyone. So these are known as aberrant epiphysis. Bone growth. As you know, we all increase in size as we age, we develop, we lengthen, we increase in height. So the skeletal framework grows with it. So it grows in two directions. One is in the long direction. Any bone that will grow, it will grow in the length and it will grow in the width. So these are through totally independent and different phenomena. The growth in the length is brought about by epiphyseal cartilages. These were the cartilages that are present. These are basically the remnant of the original embryological cartilaginous framework that was formed and that are present between the epiphysis and the diaphysis. So what it does is it has a reserve of cartilage. That cartilage is continuously multiplying and dividing. The end that is towards the epiphysis, this is the dividing part. Here the new cartilage forms, new layers forms on the epiphyseal end, and the older layers that are left at the diaphyseal end, it gradually ossifies and becomes bones. Technically, it does not ossify, it's replaced by the bone, but to understand it, it gradually it is converted into the bone, it is replaced by the bone. So this part becomes bone and the growth cartilage it moves one step further, one layer further. And then the process goes on. It moves another layer further, a lower layer becomes the bone. It moves another layer further, a bone layer is become replaced by the cartilage is replaced by the bone. So as it continues to multiply, it continues to move away from the center of the shaft. It continues to move away from the diaphysis, and this is the thing that helps in the lengthening of the bone. And without it, as the bone cannot grow. As you reach the physical maturity, when you reach the your genetically determined height, the epiphyseal cartilage it gradually disappears. The cartilage does not multiply as fast as it was. The conversion into the bone, the replacement by the bone catches up, and ultimately the epiphyseal cartilage it narrows down and ultimately disappears, and the bones become continuous across both ends. After this, the length cannot be increased by natural measures. Of course, if there is a fracture and then then there is a healing in such a way that the gap is filled, this is an artificial or mm, I must say an unlucky way to grow the bone. But the normal growth process it stops with the disappearance of epiphyseal cartilages. I have written through epiphysis written, but I think the better word will be epiphyseal epiphyseal cartilage. The growth in the circumference. I remember we talked about the periosteum and endosteum. There is endosteum lining on the inside of the cavity towards the inside, and then periosteum there is the outside. These have stem cells known as osteoprogenitor cells. These can give rise to the osteoblast also, and then there are presence of bone dissolving cells also. So what happens is that from the outside, the periosteum in the periosteum there is osteoprogenitor cells. They form the osteoblast. They deposit the bone on the outside. The bones become a little thick, and in the inside, the bone formation and absorption ratio is more in the favor of reabsorption. The inside of the bone is reabsorbed. So like this, the outside there is bone laid, inside bone is reabsorbed. Outside there is bone laid, inside bone reabsorbed, and with this, the bone continues to increase in diameter. And that's how the medullary cavity continues to widen with age. So that is how the bone increases in width. And that is stopped at an age when you stop growing. The balance between the growth and reabsorption is hit, and the bone does not grow any further in diameter. However, if there are hormonal issues, if the periosteum is still there in older age, it does not disappear like the epiphyseal cartilage. So if the bone is forced to grow, like if a person is giving growth hormones, or if the person develops acromegaly, the growth hormone increases in the body in an older age, the bone can continue to grow in the diameter in that age also, but it will not grow in size. So the person develops different features, prominent facial features. Forehead will be bossed, chins will be cheeks will be prominent, hands will be more wider and heavier. So the bones can grow in size, but the person will not grow longer in length. However, a person who is exposed, forced to grow in a younger age, if there is a tumor, if there is an abnormality that increases the level of growth hormones in the early age, then epiphyseal cartilage responds, epiphyseal growth plate responds also, and the periosteum responds also. That person grows very long in height, and that's what you see in those people who are the longest in the world, who are world record holders. So basically, they have something, some hormonal imbalance that is pushing them to grow beyond the normal average. Then there is a growth of the flat bones. Here is the picture from Langman's Anatomy Embryology. This is the primary ossification center. That is the that we talked about, the example of the freezing of an water bubble. So that's what happens. That's how the ossification occurs in the flat bones. Initially, the mesenchyme arranges around the future site of the bone in form of membranes, and then a single point starts where the ossification starts, the ossification center, and like a freezing crystal, it continues to expand and expand until it reaches the next bone and next ossification center where they meet. Now, the interesting thing that happens is when a child is born, it has still to grow a lot in the size. The bones, this is ossification center that grows till here, this is ossification center that grows till here, they are not fused with each other yet in a younger age. Between two bones, these are the two frontal bones, there is still membrane present. Between this frontal and parietal bone, there is still membranes present. So these membranes are basically, they are giving space for the future growth. So another layer of bone is laid on towards this suture, and this suture, the bones will get a little apart. Then the bones will get a little apart. Then the bones will get a little apart. So these sutures, these membranes, these are giving the space for growth of the flat bones. Ultimately, they fuse, they ossify, and becomes a suture. And where more than two bones meet, these are known as the fontanelles. You must have seen the soft spot on the top of the head of the children, and basically this is the unossified membranous part of the young bone that will gradually be filled as the bone grow, as the skull will increase in size. And an additional advantage it gives to the fetus is that during the childbirth, as it is moving through the narrow birth canal, it helps the bones to move with relevance to each other and overlap each other to help maneuver the fetus through that passage. So that's about the bone growth. Then there is a rule of ossification or growing and hypothesis. Any shaft, let's say humerus, it has this secondary ossification center and lower end ossification center. Usually they do not appear simultaneously in embryologically. One of them does appear first as compared to the other. The rule of ossification says that the epiphysis or the secondary ossification center that develops first, the epiphysis that develops from the first appearing ossification center, is the last to join the diaphysis. For example, in the humerus, the upper end, it develops secondary ossification center earlier as compared to the lower end. As you grow in size as you lengthen your arms, as you increase in height, they remain present between these ossification centers secondary epiphysis and the shaft remains epiphyseal cartilage. The epiphyseal cartilage will disappear first in this lower end where it was or in other words the epiphysis and diaphysis will fuse first in the lower end where it was where it appeared later, and the part where the secondary ossification center appeared earlier, it will continue to last longer. It will fuse with the breast epiphysis, fuse with the rest of the diaphysis later than the lower end. So this is called the growing end because this end will continue to grow long after this end because it still have epiphyseal cartilage when this one disappears. So this is the rule of ossification. Then there is a relation of nutrient artery. In the next slide, in the next slide, excuse me. Okay, then there is a nutrient artery, and there is a just give me a second. Okay, nutrient artery. Nutrient artery is the main artery of the shaft of the bone, and I will go into the detail even in the next slides. This bow artery does not go directly at right angle to the shaft of the axis of the shaft or long axis of the shaft. It is usually at an angle. It is at an angle, and that angle can be remembered by this mnemonic. From the knee I flee, towards the elbow I flow. So the direction of the blood flow in the nutrient artery, it's towards the elbow. The direction of the nutrient artery is towards the elbow. Like blood is flowing in the nutrient artery towards the elbow I flow. In the radius and ulna, it is moving upwards towards the elbow. It is moving towards the elbow. The relation to the growing end hypothesis is that is always direction of the nutrient artery is always away from the growing end. So it helps you to remember the growing ends also. From the elbow I flow, towards the elbow I flow. So nutrient artery is directed towards the elbow in all the three bones, humerus, radius, ulna. So the growing ends will be away from the elbow. So the humerus will have growing end at upper end, radius and ulna will have growing ends at the lower end. From the knee I flee. The nutrient arteries are directed away from the knee. So the growing ends will be towards the knee. The femur will have growing ends towards the knee, the lower end. The tibia will have growing ends towards the knee at the upper end. So that is the way to remember that. But please remember that the bone of the leg fibula, it violates the rule of ossification. It does not follow the same. The bones that appear first, it fuses with the rest of the shaft first also. I'm not going into the exact dates, but that happens, so it does not apply to that. Now, let's talk about the blood supply of the long bone. The blood supply of the long bone, it receives the blood through a number of arteries. That's the main artery. The artery that enters into the shaft of main shaft through a foramen, that is the nutrient foramen, then the artery entered in is nutrient artery. So that's the main artery of the bone, that is the nutrient artery. It enters the bone, it moves through the cortex, enters into the medullary cavity, and here it divides into the part that grows up and then goes down. These are the ascending and descending divisions. As it goes up, it further divides into two parts. The parts of the arteries that remains within the medullary region and supply that. The part that goes outwards and supply the cortex. the Haversian system, the osteons, the Volkmann's canals, the all the arteries that were running on the compact bone in the sides. Then these are the cortical branches that are going towards the cortex. You can see it is very interesting phenomena that bone first passes through the cortex into the medulla, and from there the central and cortical branches originate, and these supply whole of the osteon system, the longitudinally running osteons and the horizontally running perforating and Volkmann arteries. The direction of the nutrient artery, according to the rule of ossification, is always away from the growing end. Metaphyseal artery. Name indicates these are entering at the sites of metaphysis. So it enters here and they join the network of the arteries that are created by the nutrient arteries. Epiphyseal arteries. The metaphyseal arteries and epiphyseal artery, they do not have one big entry point. They are usually surrounded by, especially the epiphyseal arteries, they are usually coming from the arterial anastomosis around the joints. As you go on and study the gross anatomy, you will see that most of the joints has very extensive arterial plexi around them, arterial anastomosis around them, and these are the branches from those anastomosis, and they are entering the epiphysis through many small foramina. The metaphyseal arteries similarly are usually coming with the muscles that are attached to the ends of the bones. So they also enters through many small foramina as opposed to the nutrient artery which enters as a single artery in one through one large opening. So this is epiphyseal artery. And last but not the least, periosteal artery, whole of the bone outside on the outside, it is covered by the periosteum. From the muscle that are attached to the outside, the blood vessels are very copiously running inside the periosteum also, and through multiple small openings, through multiple foramina, they enters the shaft and they join the plexi and the cortical arteries, and they continue to supply them also. So these are the various sources through which the bone receives the arteries. One very important thing that you must remember about the blood supply of the bone is as long as the epiphyseal cartilage is present, like in this picture it is shown, as long as the epiphyseal cartilage is present, so this means the younger person, blood does not, blood vessels don't cross it. So it is very interesting phenomena. There is epiphyseal cartilage present, there is a growth plate present, no blood vessel pierces the growth plate and moves to the other end. So that becomes clinically very important because of the epiphyseal cartilages, because of the growth plates, the blood supply of the epiphysis becomes totally independent upon the blood supply of the diaphysis and metaphysis. And keep in mind, the metaphyses are usually considered part of the diaphysis when talking in the anatomy. So you might find that in the textbooks also, that they are not usually separated from the diaphysis. So the blood supply of the diaphysis is totally independent upon epiphysis. So that's an interesting thing that is seen in the children. That's why the areas near the epiphysis, these have a tendency to develop because these are the last one to supply the look at the blood here. Due to lack of the blood, in any case of pathology, diseases may arise. But as the time passes, as the epiphyseal cartilage they disappear and the bones become continuous across the epiphyseal line, the arterial system becomes continuous. The epiphyseal artery they begin to anastomose freely with the diaphyseal and metaphyseal arteries, and that will become very important, this information, when you talk about dislocation versus fractures, especially in the hip joint and femur. We will go through them when we talk about the gross anatomy. And within the bone, the arteries, in the compact bone, in the spongy bone, it's very easy. There is a lot of space and the blood vessels simply run between them and supply the central branches, they supply the bone marrow and take blood from them. And in the compact system, the vertically running arteries along the axis in the center of the osteons, These are in the Haversian system, and then there is a horizontally running arteries with connecting two Haversian systems. These are Walkman canals or perforating arteries, and through all this network, the compact bones are supplied, and they are ultimately connected to the periosteal arteries outside. So that is about the blood supply. There may be variations a little, but that's the basic gist of it. There is a word used, centrifugal flow versus centripetal flow. In younger persons, in young age, the nutrient artery is the major player. Most of the blood comes into the bone through the nutrient artery. Ascending and descending branches gives rise to central and cortical branches. Then there are sinusoids, bone marrow sinusoids, and ultimately the blood then goes to the the cortex of the bone, and then most drainage, of course there is a drainage back through that direction also, but more drainage goes from cortical part of the bone to periosteal veins, and it mostly drains to the periosteal veins. So the blood enters to the center of the bone, it expands the cortex and goes outside through the surface. So it is going from center to peripheral. This is known as centrifugal flow. Usually in a young person, this is the direction of the blood flow. So nutrient artery, medullary arteries, radial branches, cortical capillaries, periosteal venules. As you grow old, the direction of flow it switches a little. The roles are reversed a little. The periosteal arteries gain more importance as compared to the nutrient artery. Of course, nutrient artery is also anastomosing with the periosteal arteries. A lot of blood enters through the cortex through the periosteal arteries. Again, these are relative terms. Other way is happening also, but we are talking about the majority. And it goes through the cortical arteries to the bone marrow area, the marrow, sinusoids, and from then the central venous sinuses that are ultimately draining into the nutrient vein that will be more important. So in an older person, the blood flow from the periosteal arteries all the way to the medullary venous central sinus vein and ultimately nutrient artery, so this becomes important. So in older person, the flow from periphery to the center becomes more prominent. This is centripetal blood flow. The other shape of the bones, they may have various different schemas. The short bone usually lack one big nutrient artery. They have numerous fine branches from the periosteum surrounding and entering from the non-articulating surfaces. Flat bone usually have combination of both. For example, skull usually have a lot of periosteal arteries. Ribs have a lot of periosteal arteries, but they have additional nutrient arteries also. And in the flat bones, the compact bone is present outside. Like these are the outside there is a compact bone, inside there is a compact bone, and between them there is spongy bone. The Usually the flat bones are like this. So here in the middle, in the spongy part, this part is called diploe. These are called tables. So a lot of veins run in this region, in the diploe between the two tables. And then there are irregular bones. So they have periosteal arteries. They in general they lack common nutrient arteries, but they're also present. There's a combination like those in the ribs, and then there are other, it depends from bone to bone. Is for example like in vertebral column, the back of the vertebral body, the vein exits in a common vein known as basivertebral veins. Now let us talk about a little about fracture and bone healing. Fracture is simply a break in the continuity. The bone breaks. The bone does not remain a single unit, it does not remain continuous. So it can happen due to a lot of causes. You can think of many, not going into the detail. There are again a lot of types, but very commonly used at your level, at the beginning level of anatomy. Simply talking about closed and open fractures should be enough. If the bone breaks and the skin remains intact and the wound is not exposed, that is known as closed fracture. If the bone is fractured and the bone sticks out, and the skin is also interrupted, the wound becomes open, that is known as open fracture. My focus will be a little on the bone healing. The bone healing after the fracture depends upon how well the two broken ends are brought together. If the two ends of the broken bones are perfectly aligned, every raised area, every depression is in its counterpart of the broken end and it's perfectly fused, then there is direct bone healing. If there is a little gap, if there is a misalignment, then the bone heals through indirect secondary bone healing. You will go through a little, you will have develop a more deeper understanding as you move on to the histology. But to give you a little idea, in the usually every time in US you are sitting, there is a continuous process of bone reabsorption and bone reabsorption and bone making that continues the bone, refreshes the bone, and keeps it strengthened and helps in the exchange also. So it's like digging a tunnel and then closing behind it. So it's going in this direction. This is usually this is the normal process. It is going in this direction. These green cells are the bone reabsorbing cell, the osteoclast. They keep on absorbing the bone, they make a long tunnel, and the purple ones are bone forming cells, osteoblast. They line the newly made tunnel and they deposit the bones towards the periphery. They deposit the bones towards the periphery until the cavity is filled. So the osteoclast has made a long tunnel, has opened the bone, then the osteoblast line it, they make one layer, then they make others layer, then they make other layer, and whole the whole is narrowed. And this gives rise to the typical osteon appearance that we discussed earlier. That's how the bone is continuously remodeling itself. So if the bone was fractured, let us say it was fractured right here, and the bone was perfectly aligned without leaving any gaps. So these cutting cones, these tunneling mechanisms, they simply cross the cutting edge, fill it up behind it, and there is one peg, one uh, filled cone that is now across the fracture site. Then another one will come, 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 and ultimately the whole fracture site will be gradually made. So there was a fracture here, and then there was another bone that was fracture here. There is a discontinuity of the bone, but due to this cutting cone mechanism, ultimately the reabsorption and absorption and reforming and remodeling of the bone. I'm not using the word. I should not be using remodeling. This absorption and deposition of the bone will ultimately cross the fracture site multiple times, and it will make the bone as good as new. It will heal the bone and the fracture site will disappear. But this is too perfect. This does not happen always. If there is a fracture and there is a gap, this is a secondary bone healing. That is what happens in the other cases. There was a normal bone, you got a fracture, a gap was created. Even if the bone is approximated, the bone was not opposed very well, there is usually whenever the bone is broken, the cortical bones, all the bones that were supplying the bone, blood vessels that were supplying the bone, they got torn up, and there is a hematoma, blood clot that is formed. There is hematoma formation, immediate reaction, and the blood clot, that is then fibrous tissue come and they deposit a lot of fibrous tissue, the cells granulation tissue is laid all the way here. So fibrous tissue and lot of cells are present that are replacing the hematoma. So this is known as soft callus. This is non-ossified. This is majorly fibers and cells, but it is giving some strength, some structure. Then This fibrocartilage, that is fibrous tissue, it is gradually ossified. Then the bone forming cells, they migrate into it, osteoblasts migrate into it, and they ossify this structure, they replace it by bone, and this hard callus is formed. This is still very different from the normal bone because it lacks the regular arrangement, the osteon system, the lamellar arrangement. So this is the woven bone, this is the hard callus that is formed. Then the whole tunneling process that we discussed here, it continues and gradually replace the callus with the normal bone. The excess bone is gradually reabsorbed from the outside, from the inside, and with time, the normal anatomy is restored. So this is the bone remodeling. So these are the cycle through which the bone moves after the fracture, the hematoma formation, granulation tissue formation, that is soft callus formation, hard callus formation, and bone remodeling until optimal anatomy is restored. It is usually close to, if not perfect, to the previous anatomy. Markings on the bones. There is a lot of markings. I will try to show you. Okay, there. This is a picture from the Snell's regional anatomy by regions. Let me show you. Give you a little example one by one. I have opened on my screen a 3D model of skeleton. It is with from the Complete Anatomy by 3D4 Medical by Elsevier. So I will be showing you the examples that are visible to you on the slides. Elevations, any lines, a little elevation. These are lines that are present. These are elevations in the form of lines, simply known as lines. Like these are knuckle lines. This is the superior knuckle line. My mouse cursor will be available on the complete anatomy model. These are the lines. Mm, okay, superior knuckle line of the occipital bone. Similarly, okay, these are the superior knuckle line of the bone, and there will be a lot of lines also. Like a line will be present here, and the I'm having yes. This is the intertrochanteric line that is present between this greater trochanter and lesser trochanter. This will be intertrochanteric line. So these are the lines. Ridge. This is the raised areas. Ridges. These are the medial lateral supracondylar ridges of the humerus. Like these are the basically sharp raised areas. Let me show you right here. This. This is a sharp area. This is a ridge. Like a ridge, you can palpate it on this raised area on the side. This is a ridge. That is a sharp raised area that is going up. The medial and lateral supracondylar. Crest, it's like a ridge, but it's not that sharp. It's usually a little blunt. So, like the hip bone, this is a crest. This part, the up, this part of the hip bone, this part of the hip bone, it's raised. It's that not that much sharp. You can feel it on your side of the trunk. You can palpate it down to find that this is a linear elevation, that is a ridge. Then there is tubercle, um, a small prominent elevation, that is tubercle. Like here, this part is pubic tubercle. This part is pubic tubercle. Then there is protuberance. This is a little bigger tubercle, basically. Protuberance, like this area between these lines, this area is raised. This is external occipital protuberance. Tuberosity, again a bigger term. Tuberosity, there is an example of Yes, this is the tuberosities of the femur. This is the greater tuberosity. This is the lesser tuberosity of the humerus. Trochanter, like these areas in the femur, there is the this whole prominence. This is the greater trochanter. This prominence, this is the lesser trochanter. It is bigger than the tuberosity. Malleolus, it's the prominences around the ankle. Like, let me show. These parts, this area, that is the medial malleolus. This area, these are lateral malleolus. You can palpate them along your finger, along your ankles also. Sharp elevations, like spines, these are called spines. In the vertebral column, these are spines of vertebra. This backward projection, you can actually feel them on your back. This is the spine of vertebra. Here in the hip bone, there is this spine. This is a pointed projection. This is a spine of ischium bone. Then there is a styloid process. It's like a stylus. It's a projection. Let me show you in the skull. You can see this one, this projection. This is like a pencil, like a long nail, long tooth. This is like a stylus. This is the styloid process. This is a long projection. Expanded ends, these are the heads, like this part. This is the head of humerus. Like this part. This is the head of femur. Okay, condyles. These are knuckle-like processes on the sides. Let me try to get it again. These are condyles. I'm having a little trouble in zooming it. Yeah, this is the condyle of humerus, condyles of humerus. When talking about tibia and fibula, humerus, and give me a second. So these are the condyles. Like you can see at the lower end, this whole area is uh, there are two condyles. This whole area and this whole area. This is condyles. These are two condyles, two raised areas of the tibia. This is tibial condyle. This is tibial condyle. Epicondyle, a small projection on the top of the condyle. This is epicondyle. Like this area on the top of condyle. This prominence on the top of this whole prominence. This is condyle. This small area on the top of it. This will be epicondyle. So these are epicondyles. Similarly, the ones will be present here. This one whole will be condyle. This whole area will be condyle, and this prominence will be epicondyle. Then there are facets for articulations. Facet, notch, groove, fossa. Um, this will be well seen like this. like this acromion, this is the facet of flat surface that is helping it to make a joining with the next bone, that is a facet. Similarly, such facet will be present where the head of the rib here joins the vertebral body. Notch will be a little dip, a little gap, like this is a notch. This is a notch in the continuity, notch in the sharp border. This is a notch, and then there is a groove, like any groove. This will be a groove, like this area. Groove in the humerus. This will be bicipital groove. Fossa, a dip, a gap in the fossa. This whole part is called iliac fossa. It's like a cup shape. It's like a fossa. If you look at the femur, like this is a depression, this is a fossa of the head of femur. These are fossa. Then the fissures, the slit like opening between bones. Let us see this. This is the skull, like there is a slit like opening between the bones here. See this one, this is inferior orbital fissure. Here this is superior orbital fissure. These are fissures. Openings are foramen. Here is a foramen, infraorbital foramen, and here are multiple foramen. This is a foramen connecting it to the cranial cavity. Canal, if there is an opening that runs for a long time inside the bone, that is called canal. For example, here is a foramen and here is a foramen, and within the bone there is a canal that runs to connect these two, so this is known as a canal. And meatus is simply an opening. A very good example is the opening of the nose. This is external auditory meatus. So I hope I did was more helpful than confusing. So these are the different names. You will they're maybe very new to you right now, but as you move along and you will read about in the different regions of the body, you will get a better hold of these. Let us finish the lecture by talking a little bit about the cartilage. What is cartilage? It is a specialized form of connective tissue, semi-rigid in nature, in which cells and fibers are embedded in gel-like matrix. It is different from the bones in a sense that it is not calcified and not rigid in that form. It is similar to the bone in the sense that it can hold its own shape, it's semi-rigid and gives some support to it. So it is strong but flexible. Flexibility is a feature that is different from the bone, and it is capable of sustaining considerable mechanical stresses. They usually, except of fibrocartilage, do not have blood vessels in them. We studied that example as we talked about epiphyseal cartilages. There are three main types: haline cartilage, fibrocartilage, elastic cartilage. Let's talk about haline cartilage and what are they, where they're present. Exact histology we will discuss in the histology lectures, but here haline cartilage are the most common type. When seeing under microscope, they are homogeneous. They have very glassy appearance. Even if you see in the fresh tissue, they have very transparent glassy appearance, and even under microscope, they have very uniform appearance, homogeneous appearance, glassy appearance, and they are very strong to wear and tear, able to sport, and due to the absence of blood vessels in them, they have a very poor regenerative repair tendencies. When they are damaged, they usually remain damaged or take very long time to heal. So they are usually present. They are shown in the picture in the by the blue color here. So most of the articular cartilages. So these are the articular cartilages between two bones to provide frictionless surface. So these are the haline cartilages. Apart from this, the anterior cartilaginous part of the ribs are made up of these. All the epiphyseal cartilages were haline cartilages, and in the skeleton of the embryo, the first skeleton framework that is created, it was haline cartilage. And then there is haline cartilage, and the skeleton of the embryo, epiphyseal cartilage, articular cartilage, external nose, trachea, the upper part, that is haline cartilage. fibrocartilage shown by the red here. It is somewhat between a dense connective tissue and the cartilage. It has a lot of fibers, lot of collagen fibers among them, and then there is a small amount of matrix in them. It's more resilient, uh, can sustain stretch itself because it has a lot of fibers. It allow blood vessel to pass through them, so it has the better ability, better of them, other others, to repair itself when damaged. And usually they are present in the midline joints, like the intervertebral disc is the very good example. The disc between the joint between the two pubic bones is the example of them. All the discs and menisci present inside the joints, like knee, in the knee there are menisci present, there are fibrocartilaginous discs that are present. To deepening the sockets of the shoulder joint and the hip joint, there is labrum, clinoid labrum here, stabular labrum here. Those are also fibrous cartilages. And last but not the least, there is elastic cartilage. Elastic cartilage, by the name, it has the characteristics of being flexible. If you distort them, it jumps back to their normal position. So that is its major, and it is usually present in the organs that go distortion very frequently. External ear is a very good example. You can do a lot of distorting to this and it will jump back to its position. External tube, eustachian tube, epiglottis, and lot of cartilages, and then the lot of cartilages in the lower respiratory tract, including they are of this nature. So that's it. I hope so it was helpful for you. Let us know if any changes I can make in the subsequent lectures that can help you learn better, or any changes in this direction in a future recording that I can make. Any questions that you might have of on this topic, please do mention down in the comments. I will try to respond them as to the best of my ability. Thank you so much for listening. Keep tuned, and till next time. Goodbye.